Welcome, ladies and gentlemen. I'm Dr. Silva. Thank you for joining me for this talk on Risperdal, also known by the brand name Risperdal, and the injectable forms Consta Perseris, Rakindo, Uzedy, and Risvan. I don't know where they come up with these names, but it is available in a generic preparation. It's been around for a long time, at least 20 plus years. It was newly developed when I was in residency. And it is a dopamine serotonin receptor antagonist, also known as an atypical antipsychotic agent, a serotonin dopamine antagonist, a second generation antipsychotic after the first generation of agents, Haldol and Mellaril and Thorazine, those medications. And its mechanism of action is that it blocks dopamine D2 receptors, the D2 receptor subtype. And what that does is it reduces the positive symptoms of psychosis, including paranoia, delusions, hallucinations, and nonspecific agitation. But it also stabilizes affective symptoms, i.e. it treats mania. It's a mood stabilizer. And it also has some positive cognitive benefits and also some antidepressive actions as well. So the second generation antipsychotics were a real improvement over the first generation because they also blocked serotonin 2A receptors, and blocking that subtype of serotonin receptor causes an enhancement of dopamine release in certain brain regions. And what that does is it offsets the motor side effects of these medications. And so they had a lot less drug-induced Parkinsonism, extrapyramidal symptoms, compared to first-generation agents, especially the high-potency agents such as Haldol. Yet they were very effective, equally effective, and even better because blocking those 2A receptor subtypes also probably improves cognitive and affective symptoms. So not just mood stabilizing symptoms, but depressive symptoms, anxiety symptoms as well. And as we know, the third generation of antipsychotic agents, those are partial dopamine agonists. They have a similar pharmacodynamic profile, and they are often added on as adjuncts in the treatment of treatment-resistant depression or when you need a booster. So the second generation agents, they were very similar. They're not partial dopamine agonists, they're D2 antagonists, but because of this 2A blockade, you get the bonus in terms of affective symptoms as well as cognitive symptoms. So the mood stabilizing properties is part of the D2 blockade. You block D2 receptors, dopamine D2 receptors, and you reduce mania as well as psychosis. So you do get significantly less extrapyramidal symptoms, what are called extrapyramidal symptoms, or drug-induced Parkinsonism with this class of agents. And that includes bradykinesia, which is just an overall slowness of movement and a slowness to initiate movements, what you see in Parkinson's disease, as well as less muscles of facial expression movement, so you get mask facies, an expressionless face. You see rigidity, which is a tightness in the limbs and the torso. There's a resting tremor. That is a tremor at rest when a limb, for example, is not being moved, as opposed to an intention tremor, which you get when you go to pick something up. If you have a tremor when you go to pick something up, that is not a Parkinsonian tremor. The Parkinsonian tremor is a tremor at rest. So moving the limb actually suppresses the tremor. And a gait disturbance, which includes the Parkinsonian gait, small shuffling steps, as well as postural instability. So patients can tip over. Patients with Parkinson's disease don't correct immediately when there's a postural change, and so they can tip over and they can fall. There's a fall risk. And so those are the major symptoms of Parkinson's disease: the rigidity, the resting tremor, the postural disturbance, and the disturbance in gait. And you see all of that with drug-induced Parkinsonism. So there's Parkinson's disease, which is caused by a degeneration of certain neurons in the nigrostriatal pathway in the brain, that motor pathway. That's one disease process. This is drug-induced Parkinsonism. It's not Parkinson's disease, but it's all the same symptoms because we're blocking the receptors. We're not hurting the neurons in those tracts, but we are blocking receptors. However, if you block receptors, D2 receptors, chronically in the striatum, then you get increased risk of tardive dyskinesia, which can be permanent. So that does involve a damage to the neurons in that area. It's not the same process as Parkinson's disease, but I'll talk about tardive dyskinesia in a bit. And the risk of tardive dyskinesia is proportional to the chronicity of the blockade and also the potency. So you see it more with high potency agents, the agents that are dosed at 1 or 2 milligrams, as opposed to the low potency agents, and you see it after many months or years of treatment. It's a cumulative effect. There are interactions at a myriad of other neurotransmitter receptors that certainly contribute to risperidone efficacy, and specifically blocking the 5-HT7 receptor, that's the 5-hydroxytryptamine, i.e. serotonin 7 receptor subtype, and that's thought to contribute to antidepressant efficacy as well. So there is significant antidepressant efficacy as well as mood stabilizing efficacy in this class of agents. It's FDA approved for the treatment of schizophrenia in ages 13 to 17. That's the oral tablet, and in adults as well, but you also have FDA approval for the treatment of schizophrenia in adults using the injectable preparations, Consta, Perseris, Rakindo, Uzedy, and Risvan. So they're not approved in children. The oral form is also approved by the FDA for delaying relapse in schizophrenia. That is the maintenance treatment of schizophrenia. Schizophrenia is a chronic disease that is neurodegenerative, and it usually starts in late adolescence, early adulthood, by mid-20s in most cases, unless it's a late onset form. And it's not episodic like major mood disorders, like psychotic major mood disorders, for example, where a person has major depression or bipolar and becomes psychotic because of the mood disturbance. But then when the depression is treated and they're in remission, they have no psychotic symptoms. Schizophrenia is not that way. There may be discrete episodes that are really decompensations, they're exacerbations, where they have an acute onset of hallucinations or acute paranoia. Their symptoms are a whole lot worse. Maybe they need to go into the hospital. Their meds need to be adjusted. But even when that calms down, at baseline, they have psychosis. They have either positive symptoms or negative symptoms or cognitive symptoms, and often affective symptoms as well. There's a high comorbidity with major depression or bipolar disorder. And so when we say the maintenance treatment of schizophrenia and delaying relapse, we're talking about relapse of an acute exacerbation. We're not talking about the fact that they're asymptomatic and then we're using this medicine to keep them asymptomatic. That's just not the case in schizophrenia, unfortunately. The prognosis is poor in the long term. It's also approved by the FDA for treating other psychotic disorders, so psychosis in general, and it's approved for the treatment of acute mania as a mood stabilizer, with or without psychosis, as well as mixed mania, i.e. mania plus depression. Remember, there are significant antidepressant actions in Risperdal. And this is in patients ages 10 and older, as monotherapy all by itself, as well as an adjunct, and in autism-related irritability in children ages 5 to 16. The Consta and Rakindo injectable preparations are FDA approved for bipolar maintenance, that is to prevent the onset of mania or depression, and you do get full inter-episode recovery with bipolar disorder. So we can use those injectable preparations to prevent relapse in a patient who is asymptomatic as monotherapy, and again, those medications as adjuncts to lithium or valproate. So you might have somebody who is on lithium or Depakote to prevent relapse in bipolar disorder, and you can use these medications as adjuncts to those, so they're approved in combination. And all that means is that studies were conducted and the data was presented to the FDA, so the FDA blessed it, but that doesn't mean that this medication is not effective in other conditions, and so we certainly use it off-label because we do find it to be useful anecdotally in the treatment of bipolar depression, in the treatment of treatment-resistant depressions. Again, that serotonin 2A blockade is very useful, and we use it to treat behavioral disturbances in dementias, although it's not approved for that, and there's actually a black box warning. There's increased risk of cardiovascular events, cerebrovascular events, heart attacks and strokes in patients with dementia-related psychoses. So you're supposed to use it with just great caution in patients that have a psychosis that's related to a dementia. But we use it also to treat behavioral disturbances in children and adolescents, and we use it to treat disorders associated with impulse discontrol, problems with like gambling or intermittent explosive disorder, or even personality disorders that feature impulsivity prominently, and it's also used quite frequently in post-traumatic stress disorder. The primary target symptoms for Risperdal are the positive symptoms of psychosis, hallucinations, delusions, paranoia, agitation. The negative symptoms of psychosis, which are affective flattening. The affect is the expression of emotion, and these individuals with primary psychotic disorders, even in the absence of major depression, will have a blunted or flat affect. Alogia, which is diminished speech. Asociality, social withdrawal. This is not the same thing as antisocial behavior. This is being asocial, social withdrawal. Avolition, which is a failure of initiative. It's a failure of a person to be motivated and to begin and to follow through on tasks. And anhedonia, which is loss of pleasure or enjoyment in day-to-day activities. A person doesn't look forward to things, doesn't get excited. And this, of course, is also a feature of depression. Depression, which is very common in primary psychotic disorders. It's very important that the clinician rule out depression when they see negative symptoms. Cognitive symptoms, probably to this blockade of the 2A receptor and also probably the serotonin 7 receptor. Unstable mood, both depression and mania, and nonspecific agitation and aggression. It comes in various dosage forms: tablets, orally disintegrating tablets, ODT, Risperdal ODT that melts on your tongue, a liquid preparation, an oral solution that you can use for patients that have trouble swallowing, children, and that sort of thing. And FYI, it's not compatible with cola or tea. I'm not sure why. I have to look that up. And then you have the long-acting injectable forms, which are not recommended for patients who have not first demonstrated tolerability to the oral form. So you have to give the medication to make sure that you know that they're not allergic to risperidone or paliperidone, which is the active metabolite, which is called Invega. But you have to make sure that they tolerate it, that they're able to take it, and that they're not having side effects that are just intolerable before you give them a long-acting injection. And some of the long-acting injections, you have to have them on an oral preparation for several weeks before you can cross them over to the injections, because the injections have a delayed onset of action. The oral preparation is dosed up to 16 milligrams. That is the generally accepted maximum dosage, and it's FDA approved to go that high. In the studies, the manufacturer, Janssen, they studied up to 16 milligrams. And so they saw a lot of extrapyramidal symptoms, a lot of drug-induced Parkinsonism. And when we started using it in clinical practice, really the average dose is about 4.5 milligrams. If you stay under 6 milligrams a day, you see a markedly lower incidence of those motor side effects. And so when you look at it, it's really over-reported when you look at the package insert. in terms of the incidence. So that there's a sweet spot where probably between 4 and 6 milligrams for those patients who really have acute psychosis or acute mania, where you see excellent efficacy with minimal motor effects. And then again, the cognitive and affective bonus benefits. So Risperdal is an excellent agent. It's definitely my favorite when I need a D2 antagonist, when I'm not even looking at the third generation mood stabilizers, antipsychotics, because they aren't D2 antagonists. They're partial dopamine agonists. I have actually a separate video. I have a playlist on those, so please check those out. But when I need a D2 antagonist, I don't ever use Haldol anymore. I don't ever, when Risperdal came out, except for when we needed an injection to calm people down, there's really no reason to prescribe a dinosaur like Thorazine or Mellaril or even Haldol, because we have the second generation was so much better. And so, but like all antipsychotic agents, you need to be careful about inducing metabolic syndrome and tardive dyskinesia. So you want to weigh all patients at baseline and track their BMI, their body mass index throughout treatment. You want to get personal and family histories of diabetes, obesity, dyslipidemia, high blood pressure, and cardiovascular disease, and document if anything is pre-existing. So you get a fasting glucose, plasma glucose, and it'd be probably a good idea to get a hemoglobin A1C, which gives you an idea of what the average fasting plasma glucose concentration has been over the last 3 months. You measure the waist circumference at the umbilicus. You take blood pressure, you get a fasting lipid profile. You just get all these baseline labs. Even in patients without known diabetes, we have to be vigilant for the rare but life-threatening onset of diabetic ketoacidosis, which is a medical emergency. And it's characterized by the rapid onset of polyuria, which is going to the bathroom a lot, urinating a lot, polydipsia, thirst, a consequent thirst when you're drinking a lot. You see those in diabetes as well. Weight loss, nausea, vomiting, dehydration, weakness, a clouded sensorium. You see delirium that can progress to coma and death. And then you also want to monitor the patient's white count. Neutropenia is rare but can be life-threatening. That's a low white count. And you want to monitor the patient for the development of abnormal movements. Again, you're monitoring for tardive dyskinesia using a neurologic exam and the abnormal involuntary movement scale. Risperdal is rarely lethal in overdose. You see sedation, you could see seizures, low blood pressure, difficulty breathing. It's not habit forming, but if you're going to stop it or switch to another medication, any psychotropic agent, you want to wean it before you stop it completely. Thank you for listening.